Hello, everybody, and welcome to November's edition of St. John's Cancer Institute's Be Inspired Speakers Series, Updates and Targeted Therapies in Lung Cancer. My name is Jean Goldsmith. I am a Development Director at St. John's Health Center Foundation. As many of you know, in January 2021, the Cancer Institute's name changed to St. John's Cancer Institute. The licensing agreement allowing St. John's to use the name and likeliness of John Wayne on the Institute and the fellowship program expired at the end of 2020. The change is in name only. It will not impact the Institute's operations in any way, and the fellowship program will carry the name of the physician who founded the Institute, and it will be called the Donald L. Morton, MD, Complex General Surgical Oncology Fellowship Program. St. John's Cancer Institute will continue to provide excellence in research and education and cancer care through innovative clinical trials and laboratory research, the education of the next generation of surgical oncologists and scientists, and of course, state-of-the-art treatment for our patients. Going forward, we will expand and deepen our focus on our main pillars of cancer research, immunotherapy, molecular medicine, and genomics. Before we get started today, I have a few housekeeping items to share with you. We would love to hear your questions today during the webinar. As you will notice, everybody but the presenters are muted so that we can better hear them speak. In order to ask questions, you will need to use the chat function that is on your screen. The chat function looks like a thought bubble and it's located on the bottom of your screen. We will see your question and make sure to ask the physician. If we do not get to your question during the webinar, which does happen sometimes because we have a lot of questions that are coming through, we will make sure to follow up in an email to everybody with the answers to your questions. If you have a question after the webinar, please email us and we will get that answer to you as well. You can communicate with us by replying to the emails that we have sent to you. We have a very interesting hour in front of us as we hear from a cardiothoracic surgeon, a medical oncologist, and a radiation oncologist who all work with lung cancer patients. They are all clinicians and researchers and work closely with St. John's Cancer Institute's research labs to make strides in the treatment of lung disease. I'm very honored to introduce the panel today. One of our panelists is Dr. Robert Mckenna, who so many of you know. He is the director of minimally invasive chest surgery and thoracic surgical oncology, and an internationally renowned thoracic surgeon. Dr. McKenna's book, The Atlas of Minimally Invasive Thoracic Surgery, is a guidebook for all thoracic surgeons on VATS, or video-assisted thoracic surgery. He pioneered the technique and he's performed the most VATS surgeries in the United States. Dr. McKenna, I happen to know that you are not the first oncologic surgeon in your family. Can you tell us about how your father's career in medicine influenced your career decisions? And you may want to unmute, Dr. McKenna.
So when I was in junior high school, thinking about what I might want to do when I grew up, I went to watch my father operate and thought, well, that looks cool. I'd like to do that. Maybe I'll go that direction. And here we are, 45 years later, doing cancer surgery. He trained at Memorial Sloan Kettering. The two most famous cancer hospitals in the US are Memorial Sloan Kettering in New York and MD Anderson in Houston. So anytime my dad or I would talk about cancer hospitals, I'd tell him, well, I went to the #1 cancer hospital at MD Anderson where I trained and was on the staff a couple of years.
Thank you, Dr. McKenna. Our second panelist is Dr. Robert Woolman. He is a board-certified radiation oncologist. Dr. Woolman has lectured widely on treatment selection in prostate cancer, written about hormonal regulation of breast cancer, and also malignant melanoma. His areas of expertise include prostate, bladder, lung, breast, brain, head and neck cancers, skin cancer, partial breast irradiation, stereotactic radiosurgery and radiotherapy, and IG-IMRT. Dr. Woolman, what are you most hopeful about for the future of radiation oncology?
Well, thanks a lot for inviting me to be here with this fantastic panel of colleagues and friends. Radiation, to answer your question, what I'm most hopeful about is it continues to become more and more precise. We always hear about precision medicine in cancer treatment, and that's one of the hallmarks of radiation in the modern era. It used to be, I mean, when you talk about things improving, it makes it sound like, oh, we used to just splash radiation all over the place in the old days. And in a certain sense, we did. And radiation has gotten much more precise, so we hit what we want to hit without hitting the nearby tissues. And the machinery is better, the software is better, and the speed with which we're able to deliver the treatments is better. So I'm very hopeful that that will continue, and we'll get more cures with less side effects and more ability to coordinate with medical oncology and surgical oncology as we've been doing over many years.
Thank you. That's great. Our third panelist is Dr. Sean Fisher. Dr. Fisher is a hematologist and medical oncologist with Santa Monica Hematology Oncology Medical Group. He is the director of inpatient medical oncology at Providence St. John's and is an adjunct professor of medical oncology at the St. John's Cancer Institute. Dr. Fisher, what is the most exciting treatment development for cancer patients you have witnessed in your career?
First of all, thank you so much for the opportunity to speak today. It's a very important topic, and thank you once again. Great to be with you all. So I would say, in terms of the breakthroughs that we have seen, really just in the past few years, it has been nothing short of miraculous. I mean, if we would have envisioned a situation where patients with advanced lung cancer, people with metastatic cancer, could live years. I would have kicked myself 20 years ago when I was at training, where we really just had one chemotherapy option. So I would say the advent of immunotherapy in conjunction with all of these targeted therapies has really revolutionized the way we practice lung cancer oncology. And it is really, I think, now a personalized approach in how we treat each individual patient rather than just a blanket chemotherapy approach.
Thank you. And I'm really personally excited to hear about all the changes that have been going on in the last couple of years. I mean, it's made a huge difference for patients. So that's fantastic. Moderating today is Dr. Neil Martin. He is the interim executive director of the St. John's Cancer Institute. Dr. Martin is also a neurosurgeon and is the regional medical director of neuroscience for Providence, Southern California, which oversees neurosciences for Providence hospitals and clinics across all of Southern California. Thank you for moderating today, Dr. Martin, and take it away.
Well, thank you, Gene. It's a pleasure to be here. I want to thank you and the foundation for all the great support we get in the Cancer Institute that enables us to develop programs like this and to pull together world-class specialists like these three physicians who are highly experienced, universally renowned, and will be able to provide us with a tremendous amount of information about lung cancer. Dr. Fisher, if I could start with you, can you give us some background? You know, how common is lung cancer, and what are the different types of lung cancer?
Sure. So lung cancer is the #1 cause of cancer mortality in the world. 1.8 million deaths worldwide reported in 2020, an incidence of about 230,000 cases of lung cancer reported in the United States annually. The majority of lung cancers are tobacco related, accounting for about 80% of those. There are other risk factors for lung cancer that would include things like environmental exposures, radon, occupational exposures, et cetera. And I would say that in terms of the types of different lung cancers, we have two broad categories. We have something called non-small cell lung cancer, which makes up about 80% of all of our lung cancer cases. And then 20% of the cases are what we call small cell lung cancer, a less common variety of cancer, all generally heavily linked to tobacco exposure.
And you know, we hear about mesothelioma as well. Is that a cancer that you encounter frequently?
Mesothelioma is more of an asbestos-related malignancy that I don't see nearly as commonly as non-small cell lung cancer or small cell lung cancer.
Dr. McKenna, you're asked to see a lot of patients who are being screened for cancer. How is lung cancer screening ordinarily done, and how do you decide which cases need a biopsy, which cases need surgical removal?
In lung cancer treatment, we've been behind breast cancer, colon cancer, and prostate for several years. But two things have made a huge difference in just the last couple of years. One is targeted therapy that Dr. Fisher mentioned, but then also screening. There was a big study in the New England Journal that showed a 20% reduction in the death rate from lung cancer if you screen patients. This means finding people with a 30-pack year smoking history, age 55 to 80 years of age, and that they smoked for at least 20 years. So when you find those patients, now the standard recommendation, and a recommendation that all physicians should follow in taking care of their patients, would be patients that have those characteristics, and they should recommend to those patients that they get a CT scan of the chest once a year.
You know, as a surgeon, many times in the preoperative evaluation, the chest X-ray shows a nodule. What needs to be done to evaluate whether a nodule is something benign or whether it's potentially cancer?
30, 40 years ago, it was just, well, get a follow-up chest X-ray or CT and see if it gets bigger, and then potentially look into what it might be and might get a biopsy. That's very different now. The CT is really important because if you do CT scans on everybody, 1 in 3 people have something in the lung. And you really need to be an expert to know which nodule you worry about and which one you don't. Even though 1 in 3 people have a nodule, only 1% of those are cancer. So it's kind of tricky to not do unnecessary tests and not expose people to the bit of radiation from the CT scan, but at the same time, not sit and watch what turns out to be a cancer. So things that can be done would be CT guided needle biopsies in the chest. There's a new system, which is like a GPS system. It's a computerized robot that allows us to get out to the edge of the lung to where the lung cancers are and get a sample. And with a high sensitivity, we're able to tell what nodule is a cancer and what nodule is not a cancer. And we're very excited to have that sort of GPS bronchoscope here at St. John's.
So that's a bronchoscopic technique that's done minimally invasively, just like endoscopy and other organ systems.
Right, it's an outpatient procedure. The bronchoscope is flexible. You go down through the mouth and out to the edge of the lung to the spot where the tumor is, and are able to get a biopsy with 90% sensitivity to find it and diagnose it.
Dr. Woolman, radiation therapy plays such a key role in the management of so many different kinds of cancer. How does it fit into the treatment planning for patients with lung cancer?
So as Dr. Fisher was saying, broadly speaking, there's 2 general types of lung cancer: the small cell lung cancer, which is much rarer than the non-small cell lung cancer. For small cell lung cancer, most of the time, but not always, after a biopsy, it's treated with both chemotherapy and radiation therapy. And as Dr. Fisher will probably talk more later, there's a lot of new excitement about immunotherapy as well. So radiation and chemo are kind of the cornerstone of treatment for small cell lung cancer, although sometimes there is surgical resection as well. So radiation is sort of a mainstay of the treatment for that. It's also a mainstay for the treatment in non-small cell lung cancer when it's found very, very early and the tumors are very, very small. Sometimes they can be treated just with 3 to 5 treatments of a very focused type of radiation called stereotactic body radiation, or SBRT. That's in non-small cell lung cancer. We also do use the other types of radiation, more broad field radiation, sometimes for non-small cell lung cancer as well, along with chemotherapy too. So kind of a large answer to your question. It can be used in the right setting for both non-small cell and small cell at both the earliest stages and the later stages.
So explain to us, you know, when someone is getting radiation therapy to a lung mass, a lung tumor, how do you, and you're doing it with a focused technique, what do you do? Tell them to hold their breath for 30 minutes, or how do you account for the movement during respiration?
Great question. So when we're treating a very focal small tumor, before we do any radiation at all, we have the patient come to what we call a simulation, which you can kind of think of as a fitting, where we put them in the position we want to do radiation in, and we make kind of a mold that compresses the chest a little bit so they can't take huge deep breaths in and out. So when they breathe with this kind of mold, they just take smaller breaths with much less excursion of the diaphragm. So that prevents the tumors from moving a lot. Then we do a CAT scan with them breathing in that mold, and we take the information from the CAT scan and we put it into the radiation targeting computer. And then I can really see, in relationship to the external surface of the body, where the tumor is throughout that respiratory period. And we target the tumor at its highest level and its lowest level with the respiration. That's the way we usually do it. Sometimes, if there's still a lot of motion, we have the patient hold their breath for 20 seconds instead of 30 minutes, because the radiation, even though we say it takes 5 to 10 minutes to deliver, the beam's usually only on for a minute. So most people can hold their breath for 20 seconds, then we tell them to breathe for a minute, hold their breath for 20 seconds, tell them to breathe. So there's a way to do it with something called respiratory gating, which is the second thing I described, but usually we don't have to do that. Usually it's just a little bit of a mobilization and precise targeting with the computer and the machine.
I see. Okay, fascinating evolving technology. It's amazing to see an animation of exactly how that works. Dr. Fisher, can you run down the types of drug therapy or non-radiation, non-surgical treatments that are available now, and how they might be administered?
Sure. So that's a very broad question, Neil. But what I would say is that the applicability of these systemic therapies, these pills or these IV therapies, really depend on our situation, right? So when somebody's diagnosed with a lung cancer, the lung cancer team, the surgical oncologist, the radiation oncologist, the medical oncologist, we stage the patient and we determine the extent of the disease. And based on the extent of the disease, one will be assigned a stage with a particular treatment protocol. And there are different systemic therapy options. I use the word systemic. This is just a way to describe a treatment that we're giving either by pill or by IV infusion. And there are a number of different options as it relates to systemic therapy. And again, it depends on your clinical scenario. So you may treat somebody with a stage 2 lung cancer with what we call adjuvant therapy. These are therapies that are designed to reduce the risk of cancer coming back after a definitive surgical procedure. You're going to obviously use different approaches there than you would in somebody with stage 4 cancer, where there may be metastatic cancer in another organ. So in terms of the broad categories of treatment, there is chemotherapy, which historically has served a purpose and still continues to do in certain situations. There's targeted therapy. Targeted therapy are therapies that are designed to inhibit the function of a particular cancer-related protein. Most of these targeted therapies, not all, but most, are pills. And then there's immunotherapy. And there are many different immunotherapy drugs available, but all basically have the same mechanism of action. And I could elaborate further, but it's a pretty broad overview of how we would approach systemic therapy.
So chemotherapy is what we used to think about. That was it. That was the mainstay. But now immunotherapy is definitely on the rise, and targeted therapy seems to be as well. How would you rate the importance of the three of those, or the frequency of use of the three of those in today's world?
Yeah, so unfortunately, as it's still the case, the majority of patients who present with lung cancer present with stage 4 disease. That's just an unfortunate reality. So
Yeah.
most people never get that chance with Dr. Mckenna to have a surgical operation with curative intent. So when I was in training 20 years ago, we had really a couple of chemotherapy regimens. These would be a combination of 2 chemotherapy drugs that are non-selective, non-targeted, with the idea that these are chemicals that just kill cells that grow fast. And in 2003, there was the approval of the first targeted therapy, which was called gefitinib or Iressa. And then there was a subsequent drug called Avastin, which we still use to this day. Those were the first 2 targeted therapies. Now there are 34 targeted therapies FDA approved 20 years later for lung cancer. And it really depends on what target we're trying to use. And just kind of a basic schema is, for people with advanced cancer, we try to go down kind of an algorithm. We try to say, okay, is this a patient where we can identify a target and put somebody on a very focused targeted therapy?
Mhm.
And if they're not a candidate for that very focused targeted therapy, then the transition is to immunotherapy. And sometimes immunotherapy is given by itself, and sometimes it's given with chemotherapy.
Mhm. Okay. Dr. McKenna, can you tell us how the surgical procedures done for lung cancer today, and how have they evolved over the years? I know that you have played a seminal role, a critical role in the development of minimally invasive cancer techniques, but is all cancer surgery minimally invasive now? Perhaps can you give us an overview of surgical techniques and technology?
About 95% of what I do these days is different from what I was trained to do. So in the 1930s, any lung cancer operation would be taking out the entire lung through an incision that was 8 to 10 inches long. And then in the 50s, we took one lobe out instead of the whole lung. And then in 1992, I did the first minimally invasive lung cancer operation, which meant taking small incisions about 1/4 of an inch or 1/2 inch in diameter, and put tools in through those little incisions and look at a TV monitor up on the wall to do the same operation that previously required taking out a large piece of lung, and through those big incisions that hurt more and had more complications, and drew out the recovery for that. So that's made a huge difference.
And tell us a little bit more about how the new technology that allows you to get all the way out to the lung periphery works. How, it's a GPS-like system, but how in the world can the map be made, and how can the tracking, the position of the endoscope be done?
Well, there's several ways that it can help us doing operations. Number one, some nodules that we find these days are small. They may be 1/2 inch in diameter. We can't really feel them. You can't see through the lung tissue to spot where that tiny nodule is. So we have the radiologists help us by putting a wire into that spot. So when we go operate, we look inside and take out the part of the lung that's got the wire. The GPS system is something we can use intraoperatively during an operation to help find that spot and take it out. A couple of years from now, we're going to be able to treat with that GPS system as well. there's a probe that you can put through the bronchoscope out towards the edge of the lung. Currently, it's still experimental, but we're not too far away from being able to do that and get the fiber out into the small lung tumors and heat them up to 200 degrees and kill tumors that way. So it's a combination of different physicians and specialists that are able to make a difference and change what we do that way.
Yeah, it's quite an amazing evolution in the technology. So for the minimally invasive thoracoscopic operations, the video operations,
Right.
are those done on patients in the hospital? Do they stay overnight? Can it be done as an outpatient?
Well, in the country, the average stay in the hospital for a patient after lobectomy has been about 7 days. For a minimally invasive operation, it's more like 2 to 3 days. It's not an outpatient procedure yet, but we cut in half the length of stay in the hospital for those operations. Patients hurt less, the complication rate is lower. Patients are able to get back to their activities quicker.
Yeah.
Got a woman who had an operation on Monday. She went home on Tuesday, and she did spin on Friday. Had a couple of men who played tennis a week after they had their operation. And then I had a woman who, girl power, had her operation, was in the hospital just 1 day, and she played tennis 4 days. So not everybody gets home from the hospital that quick, but we are certainly shortening the length of stay, reducing complication rates, and helping patients. And if we can do the screening to find tumors when they're small and early, that's very important because the cure rate is so much better if you find a stage 1 lung cancer that's tiny and you can do these minimally invasive operations and get through it quickly.
So, as you were describing the old days, I remember those as an intern, and the patients universally had a big chest tube in place to prevent the lung from collapsing. Is that still part of the procedure?
They still have chest tubes, but we've changed the techniques in which we do the operations and separate one part of the lung from the rest, so that we've reduced the length of stay in part by not having to keep the chest tube in as long.
I see. I'm assuming the tennis players have their chest tube out.
Exactly.
Sean, we're starting to see interest around this concept of liquid biopsy. In other words, a blood test to diagnose cancer. How does that work into the diagnostic process in lung cancer?
Great question. So this is this kind of a brand new concept of over the last perhaps 5 years or so, where we're actually sequencing the genes of cancer cells to help guide our treatment options, these targeted therapies. And as I mentioned, there are so many new targets. It's like there's a new target each week, it feels like, with a new accompanying drug available for use. So I think, we generally, if possible, prefer to obtain a tissue biopsy. That would be biopsying, perhaps a metastatic deposit of cancer, if that were the situation, or perhaps taking a tumor that Dr. Mckenna resected and sending it off for this kind of sequencing, which is often referred to as next generation sequencing. It's a very broad panel of genetic testing looking for genetic alterations, gene mutations, et cetera, in cancer cells. Now, a lot of times, biopsies are just not feasible. You may have a cancer spot in a location which wouldn't allow for a safe biopsy. And if this is a situation where there's advanced cancer, you can simply do a blood test. The patient will come into the office, you draw a blood test, and you're really able to look for cancer DNA from malignant cells floating around in the serum, and you can, for the most part, obtain the same information that you do with a tissue biopsy doing the same testing. And there are some, myself included, who are often doing both, because sometimes liquid biopsies will pick up something that a tissue biopsy would miss. So they often are done in in unison, and the information is sometimes very, very impactful.
So,
So the GPS bronchoscope can help Dr. Fisher with this as well.
yeah.
That cancers are smart. We can find a target, and he can use a target chemotherapy for a period of time, and then the tumors change and they morph into something different, and then that medicine doesn't work anymore. So then we can use the GPS bronchoscope to get a biopsy to see what new genes are present in the tumor. So he can switch to a different medicine, turning lung cancers almost into a chronic disease. You treat it with one thing until that doesn't work, and then we get a biopsy and see what changes that tumor has made and switch to something that'll be more effective.
It's a great point.
And these days, 2/3 of lung cancers have some of these targets in the tumor. So that's dramatic, and that's going to make a huge difference in the survival rate for this. As early as just a few years ago, chemotherapy, the traditional kind of chemotherapy, didn't make a huge difference in survival. Like stage 2 lung cancer, getting chemotherapy would only get an additional 5% survival with traditional chemo. But a paper that came out just last year showed a certain target. When you give that to patients after we do an operation, it was a 40% improvement for the survival rate for patients that have that target and can be treated with that medicine. So it's a combination of different physicians and specialists putting together all these different things to make a huge difference in survival rates for lung cancer these days.
Yeah, it used to be that we would look at the cells of a tumor stained in the pathology lab for different sorts of chemicals to make a diagnosis. Now we're looking right into the DNA and RNA of the tumors to find out what the molecular events are that are driving growth and metastases and hitting those with specific molecules. It's amazing to think about where we're going to be in another 5 years with this progress. Dr. Woolman, so how does, radiation is powerful energy. How does it kill tumor cells and spare normal cells?
So around the time the Curies discovered radiation, it was sort of accidentally discovered that this rock that had some radium in it that somebody was carrying, and the person carrying it had a cancer on their hand, and they were carrying this rock around, and this cancer on their hand just disappeared, but the skin and the hand was unaffected. It was the first time anybody showed that you could get rid of cancer by not removing the entire hand or part of the hand and cutting the entire tumor out. It was sort of invisible and miraculous that radiation made the tumor melt away without harming normal tissue. And there seems to be an intrinsic sensitivity to cancer cells to radiation, which causes damage to the DNA of any cell that the radiation hits. But the normal cells in our body are very good at repairing the DNA damage that's caused by radiation, whereas cancer cells are not. So when you hit a tumor and some normal tissue with radiation, within microseconds, you have all this DNA damage. And then within an hour or so, the normal cells mostly can repair the damage, but the cancer cells can't. And when you hit them repeatedly with one treatment with 5 treatments, if you're talking about stereotactic radiation, to many treatments, if you're talking about IMRT, over that period of time, you're causing more and more damage in the cancer cell and not the normal cell. And then when those cells try and divide is when they die. So it's sort of like the radiation slips a little molecular time bomb into the DNA, and then the cells die, not right away, but usually over the next several weeks to months is when the radiation killing actually happens in the body. So there's just this underlying intrinsic sensitivity that was accidentally discovered.
That's fascinating. Huh. I hadn't heard that story. Dr. Fisher, what symptoms should people be on the look for that might announce the occurrence of lung cancer?
Yeah, I mean, I think obviously cough, shortness of breath, chest pain, unexplained weight loss, coughing up blood would be a very concerning symptom. If you were capable of performing a certain amount of exercise and you had an unexplained drop in your exercise tolerability, I mean, that would be something else to discuss with your doctor and get the appropriate imaging.
How many people actually develop some kind of symptom before they're diagnosed now with all these small nodules being picked up?
I think in our high-risk population, as Dr. McKenna pointed out earlier, now that we're really implementing, CT screening, I think many are being picked up in an asymptomatic fashion and being picked up early and being offered a very high chance of being cured. So it's really only the advanced cancers that may present with an unfortunate symptom depending on the location of that metastatic spot.
In my practice, about 50% of patients that are sent to me with lung cancer have symptoms. So that means we still have a long ways to go with lung cancer screening. The cure rate is dramatically better if your cancer is found when you have no symptoms than if it's not found until you do have symptoms. What I like the best is a patient to come to see me with a spot in their lung and they have no symptoms and they can't believe they could possibly have something bad in their body because they have no symptoms. That's when you want to find it. If patients have symptoms at the time of their diagnosis, there's a big drop in the survival rate. So we need to get more people screened to find them early and more curable.
Right. Very important. So don't wait till you have symptoms. Even if you're a heavy smoker, don't wait till you have symptoms. That's clear. In certain cancer types, prostate's the one that comes to mind most frequently. Some patients with histologically demonstrated, microscopically demonstrated cancers live with those for many, many years, and the cancer is indolent, doesn't grow much, doesn't harm them. Is that ever the case in lung cancer? Dr. McKenna?
Well, I hate to admit it, but there are definitely some people that have lung cancers that can just be followed and the tumors don't grow and don't travel. That's not a very high percentage. So it's a bad idea to hope that if you have a tumor that's your type and you can just live with it and be okay. You want to find it early, find it fixable before it's had a chance to travel.
That's certainly makes sense. There are other disorders that might mimic cancer, Dr. Fisher. What other things sometimes are found when a person's worried about lung cancer?
Well, of course, there's a broad differential diagnosis where, some of those very non-specific symptoms that I'd mentioned before, weight loss and shortness of breath. It could be from somebody who has chronic lung disease, or it could be from somebody that has, autoimmune disease or potentially blood clot issues. I mean, there are a number of different possibilities to account for those type of symptoms that are not cancerous. So just because you have something of concern doesn't mean you necessarily are dealing with cancer, but you should certainly have anything checked out that is concerning to you.
Smoking history is very important. There are plenty of people that I've operated on that got the message. They understood that smoking was bad. They quit smoking, and more than 20 years later, they still wound up getting lung cancer. So we wrote a paper on that a few years ago where patients who were former smokers still had a significant chance of getting lung cancer. So it's not enough to quit smoking. You need to get the screening done so you find it early and fixable.
How much smoking early in life is enough? A couple packs as a teenager, or 5 years a pack a day, or what? Just general ballpark.
Most researchers in this believe that it's either 20 or 30 pack years.
I see.
And
Okay.
that's one pack times the number of years, or the number of packs that you smoke a day times the number of years that you smoke.
Right. Okay. Dr. Fisher, let's talk about the unfortunate circumstance when somebody comes in with advanced cancer. What can be done for them? What kind of therapies seem to be most effective? What's new?
Sure, of course. So as mentioned before, first and foremost, you want to have a full assessment of where cancer is. So if somebody has advanced cancer, you want to make sure that they've had the necessary staging studies. They've had a PET scan. They've had an image of their brain, usually an MRI of their brain. And then, of course, you want to establish a tissue-based diagnosis. You want to try to get a biopsy of something. And generally that's done with a needle biopsy or a surgical biopsy. And once that information is obtained, the next sequence of steps are you send that material off for this genetic testing that we talked about before. That information that you get will tell you, are you one of those patients who has a genetic alteration that would make you a good candidate for targeted therapy? So the most common targeted therapy option is for those who have something called an EGFR gene mutation. That makes up about 20 to 25% of all of the mutations accounted for. And there are a number of different treatment options out there to address those particular problems. If you think of it this way, genes, we all have genes that encode for proteins, and proteins carry out functions. If a mutated gene in cancer, that function of that protein will be abnormal and potentially drive the growth of the cancer. And these medications are called tyrosine kinase inhibitors, which is a fancy way of saying protein blockers. So basically they block the function of those proteins that are driving the cancer. So depending on whether or not we have a targeted option, that would be the first checkbox to see. Now it gets a little confusing because there are certain medications that are recommended for people who have a targeted abnormality in the front line. And then there are people who have targeted abnormalities where the medication that they may be a candidate for are approved for later down the line. So this is just all very valuable information. Now, if a patient does not have a targeted abnormality, then we go to the next set of decisions, and that is, are they a good candidate for immunotherapy? We haven't really talked about immunotherapy, but immunotherapy are a class of medications that are incredibly novel. What they do is they essentially block cancer's ability to turn off certain aspects of our immune system, namely T lymphocytes, which may function to help eradicate cancer, but they are turned off by the cancer cells. These drugs block that interaction. And depending on cancer's ability to turn off the immune system, we can quantify that based on a test called PD-L1. The higher that number, and there are a couple of other things that are also predictive of response, but the higher that number, the more effective immunotherapy will be. Sometimes we give immunotherapy just by itself. Sometimes we give immunotherapy in combination with chemotherapy. It all depends on some of these prognostic factors that we're talking about. And of course, if somebody's not a candidate for immunotherapy, because there are some reasons to not give immunotherapy, if somebody had active autoimmune disease or something like this, because the way these drugs work is they kind of rev up your immune system. And if you already have an autoimmune condition where you may be attacking yourself, those kind of situations may get worse on immunotherapy. So those are often red flags to not use immunotherapy. If you're not a candidate for targeted therapy, you're not a candidate for immunotherapy, then you're looking at chemotherapy, which still serves a valuable role for many patients with advanced lung cancer.
Dr. Woolman, we got a question. Does a person who receives radiation therapy for breast cancer get enough radiation to the lungs that they should be screened in the future for lung cancer?
Radiation-induced cancers are quite rare. And there is no guidelines for women who've had breast cancer radiation to have screening. But having said that, as Dr. McKenna and I have discussed very often, because he has such a big practice of people, he sees a few patients every year that have had radiation behind the chest wall of irradiated breast. So while it happens, it doesn't appear to happen with enough frequency that you're going to pick this up like you would in a smoker. Like somebody who's got, as Dr. McKenna said, more than 20 peck years of smoking, they have a high enough risk that you're going to find more cancers than you might potentially cause by doing screening. So if you kept screening all these women who've had radiation for breast cancer, you would probably cause more lung cancers than you would ever pick up. I mean, the chance of getting it after breast radiation, getting a lung cancer, is probably about 1 in 500,000, maybe 1 in 250,000. So you would be screening so many people that even though it's very rare for screening to cause cancer, you would probably cause more than you'd find, unfortunately.
If I have 52 patients who got radiation therapy for breast cancer and subsequently went on to get a lung cancer in the field of radiation. So that's a scary number. We don't have enough data to be able to say if you got radiation, what group of those people should wind up getting screening CT scans. I don't know. It certainly happens. I don't think it's 1 in 500,000.
We radiated a lot of patients for breast cancer. I mean, it's a very common indication for radiation. I know you see it a fair amount, but I just don't think there's that many that you would have a successful screening program. Having said that, if you had somebody who was in their 20s or 30s that was getting radiated for breast cancer, because it takes a long, long time for radiation to cause cancer, and the carcinogenesis of radiation has a lot to do with the age at which you radiate a patient. So when we treat kids in their teens and 20s for Hodgkin's disease, that's a very common thing for them to get cancers later from radiation. Breast cancer doesn't often happen in your 30s. If somebody was a smoker and got radiation, especially when they were very young, then it might make sense to screen, but then you'd be screening them anyway because they had tobacco exposure. It's just hard to think of a scenario that you would cause enough cancers from radiation that a screening program would pick them up.
Well, we're getting some questions about risk and exposure to smoking, particularly secondhand smoke or air pollution. What's the thinking on that, Dr. Fisher? Secondhand smoke?
Certainly a concerning risk factor for, depending on how you quantify secondhand smoke, the time, the exposure. It's often something when you're young and your parents may have smoked or something like that. There's no real data out there to guide those patients at present. But certainly, if there's a concern with symptoms, then they should discuss with their primary care doctor.
So we don't have great data to really say what the risk is, but the people studying this think that maybe 2,000 patients a year will get lung cancer from secondhand smoke. And that's 2,000 out of the 230,000 Americans that will get lung cancer. So it happens. It's a relatively small percent. We're all concerned about smog and air quality. In Beijing, the average day, the amount of damaging particles in the air and smog is about 20 times the upper limit of acceptable smog, bad air quality in the United States. And some people are estimating that within a couple of years, they may have as much as 800,000 people per year getting lung cancer because of their smog in Beijing. So there's certainly some concern about that. Other causes for it, radon gas, Radon gas, some people say, is the second most common cause for getting lung cancer. And it used to be, I'd just hear about a couple of isolated areas in New Jersey and a few places around the country. But there are areas, pockets in Southern California where people have a significant amount of radon gas in their basement that comes up through their house. You can look that up on the maps. Right along the 101 freeway on the south side of it, there's a pocket of radon gas that goes from Studio City out to Calabasas. So there's some concern about that.
Hmm.
There are other chemicals that we're exposed to, asbestos that we're exposed to.
Mhm.
So the concerns, but 80% of lung cancer is related to smoking, whether it be a current smoker or former smoker.
So in follow up to that, one of our listeners specifically asked, should people exposed to significant amount of secondhand smoke, somebody else in the household is a smoker, should they go on the screening protocol of a smoker?
Unfortunately, there's no data to really be able to answer that question at this point. So I think we just have to be careful.
Yeah.
Be aware.
I would bring up something that I think is something you're going to start hearing a lot about, maybe even in the mainstream media in the next few years, which is a blood test screening for cancer. And I think this is something that you may have even seen already. There are a couple companies now that are looking at DNA methylation patterns in the blood as a screening test for cancer. So there may be a future alternative for patients who are at perceived higher risk, but don't meet that classic criteria, who may be a candidate for this this technology. It's not quite prime time, but it is, I think, something we're going to see in the next few years.
Yeah. I don't think it's going to be.
It will be important. There are 3 different companies we've worked with to do the blood test to see if there's cancer in the blood. First one we worked with had a 30% sensitivity, so that's obviously not good enough. The most recent company we've been working with, we're drawing blood samples from people that have known lung cancers and checking the blood to see if we can diagnose lung cancer in the blood. And the current company is up to about 90%. This is still, unfortunately, not quite ready for prime time. So that it's not really something that you can go get a blood test tomorrow to find out if you've got lung cancer. But this is certainly encouraging when the company we're working with now finds cancer in the blood of people that we know have lung cancer. 90%. So that's a good number.
It may not be a year from now. We're hopeful that we'll be launching the screening program with one of these blood tests here at St. John's in December, before the end of the year. Dr. Aura Gordon, who you're probably collaborating with, is one of a small number of geneticists who has access to the most validated blood test called Gallery. And that's going to be available in the context of a clinical trial within the next 4 to 6 weeks. And interested individuals can actually request the blood test from their primary care physician. It is not something supported yet by insurance, so there's a charge that's between $500 and $1,000 for that blood test right now. I'm sure the cost is going to come down, but in the St. John's Cancer Institute and the Disney Family Cancer Institute here in the Providence hospitals in LA County, patients very shortly will have access to these sorts of blood tests. It's coming quickly. Let's see if we have any other. So one of the questions that we're getting from several people is the CT scan done for screening is associated with radiation therapy to the chest. Is that a significant factor in determining how to screen, how often to get a CT scan? whether you might use an MRI scan in the interim or as a substitute. What's your thinking, Dr. McKenna?
Most centers that are doing screening CT scans are using low dose CTs. So that involves a much lower dose of radiation than the standard CT that's done.
Yeah.
You also have to put it into perspective in that when you look at data from 30 years ago, but people that got radiation therapy to the chest wall and then subsequently got chest wall sarcomas, that happened less than 0.3% that they would get that radiation. So the risk of lung or chest wall cancer sarcomas was very small from that very large, very old-fashioned method of using high dose of radiation. So I think that risk is pretty low.
One last question for Dr. Fisher. What do we have exciting clinical trials going on in the area of advanced lung cancer now at St. John's?
There are some active immunotherapy specific lung cancer clinical trials being run by some of our colleagues in the Cancer Institute. So if somebody was interested, we could make the website available for them and let them know what the options are.
Great, thank you.
It's in the galleries in the company.
And Jean. Nice to see
Okay.
you again.
Well, thank you, everybody, for this really important information on updates in and targeted therapies for lung cancer. It's incredible how much changes in a year's time, really. So I'm so glad that we're able to do these webinars, because every year I think I learn new things every year, and I'm hearing from you guys a lot. So this is just fantastic for everybody. And thank you very much for your time to do this today. St. John's Cancer Institute has a long history of treating and researching cancer. And on these webinars, we highlight the work that our cancer teams do for our patients. We can't do this work without your support. So thank you for considering how you may help support us going forward. This work is critical to your treatments for further clinical trials. And so support is critically needed for that. Thank you for considering supporting St. John's Cancer Institute. You can go to our website and donate there, or you can respond to emails that we have sent you, and I'll be very happy to get back to you. Of course, very happy to get back to you on that. So this is our last webinar of 2021, and we will start again next year with 2 webinars focusing on the genetics of cancer. And Dr. Martin spoke very briefly about Dr. Ora Gordon, a board-certified geneticist, who will be on these 2 webinars next year. And the information is really, again, just incredibly interesting, and it's being updated all the time. So there's fantastic information coming out on in the genetics area, and you'll be hearing from us in probably late January, early February for our next webinars. We'll be sending invitations out in mid-January for that. So until then, thank you again for joining us today, and from all of us at St. John's Health Center and St. John's Health Center Foundation, have a wonderful Thanksgiving and happy holidays to you all, and we look forward to seeing you next year.